Okay, guys. Good morning. And please check everything is fine on Zoom. Okay. Good morning to the listener and viewers. Today we'll be talking about a very important concept, and that concept is about the mediastinum. So those who are sitting here, they cannot see the screen, and that I need to check in. Hmm? You don't have what? I don't know why it's not displaying on the. You can. I think you can enter Zoom. That's not a problem. Yeah, yeah. So the screen is not displaying here. No problem? Okay, so you can open your from your devices. So guys, this mediastinum is a really important concept, and a lot of structures of CVP are here. And I must say that if somebody is weak with the understanding of the mediastinum, that's not a good news. So we have to be very careful by learning each and every structure. So without any further delay, so what are you looking at on your screens? You can focus there. There you are looking at an X-ray. This is a lateral view of an X-ray chest. And there are some dotted lines. So these dotted lines are showing you what? They are dividing this lateral view of X-ray chest. And they have been divided into one line which goes horizontally from the front to the back, and there are two lines which are going vertically downwards. So this transversely going line is dividing my mediastinum. We all know what is mediastinum because we have covered in the first session. So this transversely going line, which starts its journey from the front, which part of the front? It starts from the junction between the manubrium and the body of the sternum. Manubriosternal joint or angle of Louis. So this line, it passes backwards in a horizontal plane, and it goes and it intersects the bodies of fourth and fifth thoracic vertebrae. And that one is dividing my mediastinum into a superior mediastinum and an inferior mediastinum. And then the heart has been placed. Primarily, what we have in the superior mediastinum, primarily the major vessels, nerves, and these structures are present in the superior mediastinum. The inferior mediastinum is further divided into three compartments by the placement of the heart. So, in front of the heart, the area which is called anterior mediastinum, the place where heart lives, that's the middle mediastinum, and behind is the posterior mediastinum. Are we good? So you're looking at that. Now this image helps you to see what is happening. And then these are the simple modifications. This is how the things has been. You can see that mediastinum divided into superior and inferior mediastinum, and then inferior mediastinum has its three different branches. Well,
It's showing the Zoom, not here, right?
yeah, yeah. It's not showing. It's okay. You can open your Zoom. There is some problem with this. It's fine.
Are you connected to here?
Yeah, yeah. Don't interrupt it. It will be fine. Open your Zoom.
Okay.
Guys, sorry for this little interruption. So, we have said that the mediastinum is divided into superior and inferior is further divided into anterior, middle, and posterior because of the placement of the heart, which is present in between. Going further, now we are looking at this image. We have seen it before, and this image is showing us. Is there a problem? So now we've been through this image, and that is showing us the organization, and what we need to see here, where is the anterior, where is the middle, and where is the posterior mediastinum. Are we good? Okay, going further. Now, this is a very important image which shows you the sections, and primarily this part of my mediastinal structures, they are sectioned at 4 different levels, which has been represented by these transversely going lines, and we'll take one by one each section and then we'll review it on a CT image. So at the level 1, the section which has been taken, it demonstrates an image. And what are you looking at? A CT image of superior area. It's almost in the neck. We can see that what is the placement of this area, and there you are looking at in between, because on the sides there are the lung fields, and in the middle, the structure which is shown you in the middle, this area is my mediastinum. There is the heart and its tubes, because we have not reached to the heart, so we are just at the tubes. So you are looking at these tubes, and if I want to see it further, so this explains me much better. So you can see the rib cage, you can see the mediastinum, and you can see the 2 lung fields. Now here, we don't see the heart. But what we see those tubes which are going or coming from the heart and going and coming from the lower body part. So let's look into the labels. And right now what you can see, the 3 major branches which emerge from my arch of aorta. And in front, you can see the brachiocephalic trunk, and then left common carotid and left subclavian. We all know the brachiocephalic is further divided into right common carotid and right subclavian. And in front of that, what is this blue area? Any idea? This blue area is basically my left brachiocephalic vein, because this left brachiocephalic vein, it crosses all the way from left to right to join the right brachiocephalic vein to make superior vena cava. Are we good? And then we can see that this blue structure, which is like a D, that's my trachea, and this is the esophagus. Are we good? Going further, now I'm doing a section at level 2. So there is my level 2 section. Now what happens in this section? Because this section, if you look at the upper image and you try to match with this image, you can see that now we are at the level of the arch. So you are looking at the arch of aorta. So how it is there? Now we can see that because this is below. Previously we were looking at the branching pattern. Now we are looking at the arch of aorta. And there what we are looking at? We are looking at the superior vena cava. And what is this structure which is entering, which is just going backwards? That is my azygous vein, which is located on the right side. And then we have the trachea. We have the trachea. Behind that, we have the esophagus. And look at it. We can see that there are two vagi, right vagus nerve and left vagus nerve. So they are present just next to trachea. Are we good? So these are the location of these different structures. Are we clear? Going further. Now the section at level 3. So this level 3 section, we can see on this image, where is this level 3? Level 3 is somewhere here. So what are we targeting? What is this structure? Pulmonary trunk. And if I can try to interpret here, I can see the pulmonary trunk. I'm way below from arch, so I will not see the arch. But can you see this rounded structure here and this rounded structure here? What are these? This is my ascending aorta and that is my descending aorta because I'm below to the arch. So if you see in this image, the same replication, my ascending aorta, my descending aorta. Above it has been arching over. So we are seeing ascending and descending. And then what is this blue thing? That is my, what is that? Pulmonary trunk, excellent. And what is this structure? This blue structure? Superior vena cava, excellent. And what are these two? So now you are not looking at the trachea. You are looking at the trachea has been bifurcated into right and left bronchi, principal bronchi. So my trachea bifurcates at fourth thoracic vertebral level. So we will not see trachea anymore. We'll see the two branching of the trachea where it's been divided. And then on the back, you're looking at something we talk about azygous vein. And then we'll be explaining in our upcoming slides that what is azygous vein. And there's a new term here, a thoracic duct. What is this thoracic duct? I'll be emphasizing on that. And then most posterior structure, what you're seeing here is the vertebral body and the most anterior structure is the sternum. So by mediastinum, anteriorly, if somebody asks you what are the boundaries of mediastinum, you can say in front is the sternum, behind is the vertebral body. On the sides, you have pleura, and this has been filled by the lungs. So the space between the two lungs, which are enclosed in the pleural coverings, and we are talking about gradually. So this is level 3 section. So we are at the great vessels and the tubes. We are not looking hard. So for that, we need to go down. When we go down at level 4, where is the level 4 in this image? So you're looking at the level 4, and there you go. So now heart starts emerging in this image. Let's see it further. So now you can see here the heart, the two lungs enclosed in their pleura. What is that? I don't see any more ascending aorta because that is done. Now I can see only the descending aorta. Because ascending aorta becomes arch. Arch was giving 3 major branches and then it descend down. So what you should not forget, the arteries are more on the arterial system, the big vessels are more on left side and veins are more on right side. So if you are given a section, this is how you can interpret. That explains you very clearly. Even this pattern continues below as well. So I hope everything is good so far. Okay, now the contents, I shared this slide before with you. So these are the structure who lives in my superior mediastinum. Look, those who are present in the superior mediastinum, some of them are connected to my anterior mediastinum, others are connected to my middle mediastinum, and others are connected to my posterior mediastinum. That's why clinicians don't believe in superior and inferior. They straight away go for anterior, middle, and posterior. Doesn't matter. It's okay. So anterior mediastinum, what does it contain? It contains a ligament, sternopericardial ligament, and thymus gland, few lymph nodes. Thymus gland is present in infants, but in adults, you may find a remnant. But if somebody had thymus gland, then this is something really, really concerned. There are certain consequences of living with a thymus on. Then we have the middle mediastinum, We talk about that. You learn in our previous 2 weeks' time. There you are explained about pericardium. You are explained about heart and its structures. Some of the big vessels has been discussed so far. So those are the contents of my middle mediastinum. And posterior mediastinum, out of them, it has a lot. So many tubes, vessels, nerves, and we'll be going through all of them, and you are expected to be good with this. Are we clear so far? Okay, now I'm bringing here an X-ray chest. And now, whatsoever we were talking about mediastinum, we will try to see on this X-ray chest. Remember, X-ray chest, this view is posterior anterior. The person, the camera, the X-ray camera is placed on his back because a chest X-ray is always a PA view, not like other X-rays where we have AP view, anterior posterior. If I'm doing an X-ray of a bone, the camera is facing to my bone from the front. But in a PA view, we take it from the back because we want to see the maximum number of structures. If it goes from the front, sternum and other things and the heart shadow will overlie so many details. And remember, any X-ray, as I have discussed in MSK, if you are looking into any X-ray, it's always mandatory. Look at a two-dimensional picture. Don't stay with one-dimensional picture. So for the X-ray chest, if you are given, always look at a PA view and a lateral view. So the whole interpretation should be matched on both of these views. So now, what are the visible structures on this given X-ray to me? If my brain knows, I can look at those structures. So first of all, let's try to identify certain features which are really, really important. And I label this slide as mediastinal shadows. So now I have drawn for you the right border of the heart. And what is expected from you, you should be knowing what are the structures who makes the right border of the heart and left border of the heart. So this red vertically going line, which is not straight, it is wavy because of underlying structures. And then on the other side, I have left border of the heart, and which has more wavy pattern. It's not straight. And why this is wavy? Because presence of underlying structures. And let's label it one by one. There are other structures. Please, when we are interpreting any X-ray, air appears black. I'm talking about X-ray. I'm not talking about CT or MR. Air appears black. Bone appears white. And soft tissue, if they appear little bit gray. So you should be understanding in between this contrast. The blood-filled cavities, blood-filled chambers, they also appear grayish white. So this concept has to be very, very, very clear, especially while we are going into the lung fields, where we are looking at different structures. So now, let's go further. What I've done, I've drawn a line which is going across from my right border to left border of the heart, where close to its diaphragmatic surface. Why I'm doing that? Now I want to measure. I'm measuring it on an X-ray. I'm measuring from one side of the rib cage to the other side of the rib cage. So I'm taking these two distances. And taking these two distances are important. By knowing these lines, I can estimate that this person is having a normal heart or an enlarged heart. Enlarged heart is called cardiomegaly. So how these lines are helpful? Can you see this red line? Whatsoever is the measurement of this red line, if the black line is equal to or less than half of this red line, that means this heart is of normal size. But if the black line distance is more than half, then this heart is being enlarged. This is called cardiomegaly. So this established to help me to understand cardiothoracic ratio. So anything equivalent to half or less than half means the heart is of normal size. An enlarged heart, this black line will be increasing. That distance will be more. And this is one of the factors which we determine when we look into any given X-ray chest. Are we clear? Going further. So now, this is you're looking at the diaphragm. Now, you may ask me why diaphragm is appearing white. It's a muscle. But underneath, what lives under the diaphragm primarily? Liver. Liver is full of blood. And there are, this is the basically contrast. And then you can see now the structures who are contributing in making right border of the heart. Above, you are looking at superior vena cava. In the middle, you are looking at which atrium? Right atrium. And at the bottom is the inferior vena cava. So now, if I label these structures, now you can understand them. Before they were there, but I was not connected. Now coming to the left border, this raised area is because of presence of the aortic knuckle or arch of the aorta. And this is because of the pulmonary trunk. And these are the appendages. So because of these underlying structures, this border is being wavy. It's not straight. And then we have the left ventricle. So if somebody asks you, name the structures or identify the structures making left border of the heart, right border of the heart, you should be connected to this. It's a very frequently asked question in OSPE. Are we good? Okay, going further. Now, I have introduced something in the middle, which was not shown there. Can you see now it was a little bit black if I compare with the contrast? Because my mind didn't knew about it, so I was unaware of that. That is the trachea, the outline of the trachea, and then you can see it's been bifurcating at the fourth thoracic vertebrae into right and left principal bronchi. Are we clear? Okay, going further. So now I'm presenting different changes in these mediastinal shadows. Guys, we are not bothered with the diagnosis, but we are bothered with what? Can we appreciate that there are certain changes? If you can understand the changes, you are done. Once you will be in advanced level of your learning, you will be expected to give the diagnosis. But currently, you should be able to understand what structural changes are there. Nobody asks you what is the clinical condition. So now, look at this heart. How it is different from my previous image. Is it the same or different? Different. What is the difference? So you can see simply there is a cardiomegaly. And without saying, medicine is all about evidence. I cannot say on my guesswork. I should have some documentation. So this is a clinical condition. If you know it, it's okay. If you don't know it, it's okay. We are not bothered. But we are looking at the right and left borders of the heart. They are different. And now, if I measure this one, and if I distance, I minus the distances, and I'll figure it out. The black line is longer, is bigger than half. So it's a case of cardiomegaly. Are we good? Okay, going further. So what are you looking here in this situation? Lung collapse. Where lung collapse? Any idea? Right or left? Right. Excellent. You guys are smart, mashallah. Shatir. So there is, I identified that area with something green circle. But look at it. Whole of this area, this is different. It is more whitish. If I compare with this side, I can see a significant difference. And that is, you may not reach to that this is bronchogenic carcinoma. This is an enlargement. This is a consolidation. This is something hazy. And if this is a bronchogenic carcinoma, or if this is a mass, I cannot say on an appearance unless I have tissue diagnosis that this is a cancer or not a cancer. So if there is a mass here, it is prone to compress the structures which are present in this location. So now we should be knowing what are the structures which are here. It may compress upon cords of my brachial plexus. It may compress upon sympathetic chain. If the cords of brachial plexus has been compressed, so I can have finding in different nerve and their distribution pattern. If the sympathetic chain is being involved, this patient may present to you with Horner syndrome. We talk about this Horner syndrome in MSK. So it depends on what structure, what neurovascular structure is being compressed, if ever compressed. It's not necessary that it should be compressed, but if it is ever compressed, then the patient will present with that type of picture. When we take an X-ray chest, we can see that there is an opacity in that lung field. So then we'll go for further investigation and we'll find out that what is going wrong, and then we can plan our treatment. So now, in this X-ray, what do you see? Something very obvious. Pacemaker, excellent. So you can see an extra battery and you can see its wires. They are going to different parts of the heart and it's responsible, those who are suffering from cardiac failures. So where we need to place these pacemakers. And they are placed under the skin. We have some of the cadavers with us where they have the pacemakers. When you're visiting the labs, I will make some arrangement, not this week, next week, so you can at least have a look of a cadaver with a pacemaker. And they are usually placed under the skin. So it's not like you change the battery and they are, self-maintained batteries. So it's not necessary that you should be, but you have to be very cautious while you are going through airport security check, and especially if you are traveling in US or UK or these areas where they have very strong scanners. So your advice, otherwise they will ring up. Even in the normal, it will ring up. If someone has some knee replacement, hip replacement, so these things will ring up. So you should carry some medical document with you that you had this thing. Otherwise, but there are certain warnings because of if somebody have these kind of things. So for different investigations, it should be well communicated ahead of time to the people who are doing those investigations. Yes, gentlemen, what was your question? Basically, you can see if you focus in this image, you can see these probes are going in that area, and then they are responsible. They are not connected to that, but they are in that area, and they are enough. They can regenerate the process. If you connect back when I was talking about our autonomic nervous system, what I've shown you from this cardiac impulse, once the impulse is being generated, so it starts. It's connected, and then the SA and then AV and then whole business will start, the rhythmicity will begin. So they are connected, but not exactly, the probe is, you can see the probes, they are not going exactly inside, but they are close to that. And impulses does not need direct insertion in your SA and AV nodes. Are we clear? Yeah, there are certain catches. I remember there was one very famous hospital, and there was one person who was comatose. Oxygen was connected to him, and the ignorant technician, radiology technician, he allowed, because patient was very critical. So with an oxygen cylinder, the patient was put, because if you detach the oxygen, patient will die. So they send this patient in that MR machine, and then what happens? MR machine is a big magnet. It sucks the cylinder stuck to that, and that machine was broken. MR machine is not an easy peasy thing. It's very expensive. I remember, if I'm not wrong, that it took 1 year for them. They called the engineers from the native country, they came over, and then they repair and demagnetize, but it was a mega disaster. So usually the metallic things, one has to be very careful. That's why I was not going into that discussion, that when people are going for these special type of tests where their magnetic fields are very dominant, so there are certain precautions has been taken. And these pacemakers, they're metal, and then it depends on what type of metal they have been made up of. There are certain metals which are not compatible with magnets, so they are fine with that. But obviously, the real metals, you should be, it should be well mentioned that I'm having a pacemaker, I'm having a prosthesis, I'm having this and that. Okay? Otherwise, the whole system will collapse. Anyways, so you're good, mashallah, you find it out. Other findings are also there. Now, what you're looking here? Any idea? This is very interesting. Yeah, no, patient is in ICU, so many ECG, electrodes has been connected. That is an ID or ordinary. No. Think more. Look at it very carefully. Let me give you a hint. Can you see a baby? A head and a body. Is it really a baby? Is it really a baby? Now think more. Diaphragm has been ruptured and stomach has been herniated into the thoracic cavity. There you go. So diaphragm has been ruptured for any traumatic reasons. And then stomach has been herniated into the thoracic cavity. So these all are mediastinal shadows. If I put a contrast, then I can see it. If I don't put a contrast, I will show you. An X-ray is coming, an image is coming where I might show it to you. Are we good? Now, what is happening here now? Any idea? Look at the heart. Guys, don't go for fancy things. First, look at the size of the heart. Go step by step. Is it normal or enlarged? Excellent. I achieved what I wanted to achieve. Now, focus more. What is happening? Look at this. Is it normal or unusual? Unusual. So that is a left ventricular aneurysm. It's a little bit more tricky. But you reach to this point that this is a enlarged heart or a normal heart, you did your job. Okay, now what do you see here? Let me give you a hint. Look at the left border of the heart. Where is the aortic knuckle? It's wide enough. So this is a ruptured aneurysm, aortic arch. There was an aneurysm and now it's got ruptured. So now you can see it's widened because there is a lot of blood there. How are such structures traumatized? You have, let's say you are driving, God forbidden, you got an accident, steering wheel, it impact on your chest wall. Minimum you get a flail chest. If the trauma is so severe, it might got acceleration and deceleration injuries you'll be learning. And because of that, this person has a traumatic, let's say somebody has an aneurysm. In aneurysm, what happens? The blood vessel wall thins out. So if there is an impact of trauma, it's not necessarily a sharp trauma, a blunt trauma. Like somebody blows in someone's abdomen. Rupture of aorta is possible. Rupture of spleen is possible. Somebody kicks in your back. Rupture of spleen, rupture of kidney. They are all possible. Got it? So now look at it. In this X-ray, what do you see here? Look at here. What's happening on this right side? What is this structure? This is a consolidation, lobar pneumonia, fibrosis. Okay, now, what do you see here? Now compare the lung fields. Look at it here. Compare the two sides. Heart is fine. I have no problem. But what is this? Can you see here? Pneumothorax. What is this pneumothorax? Water? No. Pneumo. Air. Pneumo. Pneumatic. So now, look at it. Because air has entered, we all know the thoracic cavity has negative pressure. There is a puncture, there is a wound, external, or there is a rupture of a bulla. Air has been leaked into the pleural space. So now air has entered. So now the air has been accumulated in that. So it's not allowing the lung to expand. Once lungs is not expanding, so this lung is being collapsed. We'll talk in detail about it. Don't worry for that. So this is a collapsed lung, which is shown with this dotted line. Guys, this needs a lot of practice. Not looking at once you become an expert, you need time. But this is a classic of a pneumothorax. Okay, now you have two images. Let's talk about pneumothorax. Now it's more clear. You can see that the lung which has been collapsed. Are we fine? And what about this other X-ray? Now focus here on the same right side. Fluid, excellent. So this fluid, most likely, it could be hemothorax, blood. Hemothorax. Are we fine? Okay, guys. So now, this is, you're looking at posterior mediastinum. Are we fine? So structures which are present in my posterior mediastinum. Heart has been removed. And from the sides, you're looking at the lung fields. The lungs lives here. These are the pleura. And these are the structures who are present in my posterior mediastinum. Remember today I was talking about in TBL when there is mitral valve stenosis, enlargement of left atrium, and what it will be compressing upon. Look, esophagus. Somebody was talking about someone who lives here. That was left recurrent laryngeal nerve. It's far, far away. And then she mentioned about a syndrome. I didn't have time, so I didn't went into so many details of that. But look at it. This is the area where my left atrium is being located. It's slightly upwards. So left recurrent laryngeal nerve, and once it's been compressed, patient present with hoarseness of voice, not dysphagia. What is hoarseness of voice? Somebody talks, what are you doing? Something like that, this type of sound. So the voice becomes, the quality, the pitch has been decreased, and see some robotic type of sound starts coming, and this happens, injury to the vocal folds and injury to the recurrent laryngeal nerve. Yes or no? Hoarseness, not harsh. No, not harsh. Hoarseness. Hoarse. No, you don't talk like a Hassan. Yeah. No, 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 no. That's a different other thing. Hoarseness of sound. So what are you doing? Something like that. You can listen to it. Google it, what is hoarseness, and you can hear it. So guys, what we need to focus. So these are the structures who are there in my posterior mediastinum. So you can see there are a lot of tubes. It could be trachea, esophagus, aorta, veins, nerves, so many things. But obviously, we should be respecting superior and inferior mediastinum. In the superior mediastinum, everything is common. In the inferior mediastinum, we have few of them are done. Let me say trachea is done. When trachea reaches inferior mediastinum, it has been already divided. So I will not find trachea if I'm given a section. And if I'm looking at one of the easiest clue, if there is no trachea, means this is a section at inferior mediastinum. Now, another view. So we are looking from the back. Are we good? So this is another view of the structures which are located in my posterior mediastinum. This is a view from the right side. Why I'm saying right side? I told you, veins are on the right side. This is the heart. This is azygous vein. And this is my sympathetic chain. Intercostal vein, artery, and nerve. Each intercostal space and its contents. Are we good? And we are looking at the posterior intercostal veins, posterior intercostal arteries. We talk about these posterior intercostal arteries on the Thursday when we are talking about coarctation of the aorta. So this is the right view of my right mediastinum. And now this is the left mediastinum. Why I'm saying it is left? Because I see here arch of aorta and descending thoracic aorta. Rest of the structures are almost similar. Are we good? So you are expected to look into the mediastinum from the top, from the side, from the right side, from the left side, and at different levels. Okay, so now let's start from the back. So you're looking at the vertebral bodies, and right now I'm starting with azygous system of veins. Azygous system of veins, there are three kinds of veins. Paul will be explaining to you in his developmental lecture. And these veins, one of those are azygous vein. Azygous vein, I call it azygous system of veins. It's complete, almost complete on right side, but it is patchy on the left side. That's why we have azygous vein on the right side, and on the left side, we don't call it azygous. We call it hemiazygous. We call it accessory hemiazygous. Now, we need to focus on the posterior intercostal vein from each space. If you recall, on Thursday, you have been explained about the organization of posterior intercostal arteries and how they were given off in different spaces. So now, let's start. This is just the organization of this image. So now we are looking at the inferior vena cava, renal vein, azygous system. Where is my azygous vein? There you can see. Are we good? Now, posterior intercostal veins, they drain into, on the right side, they drain into azygous vein, but not in every space. Not in every space. Upper spaces are not following. Guys, we all know we have 11 pair of intercostal veins, arteries, and nerves. And the 12th one is always called subcostal. Because below my 12th rib, I don't have any other rib. So we call it subcostal. Are we good? So you have seen now on the right side, what is happening? Posterior intercostal veins in different spaces, but leaving upper three spaces. They all are draining where? To the azygous vein. And we all know this azygous vein connects to my superior vena cava on the right side. Now, what I'm writing here, posterior intercostal veins from space 4 to space 11 on the right side, they drain into azygous vein. Are we clear? Now, look at the upper spaces. Space 2 and 3. They are draining into where? Right superior intercostal vein. And then it also goes to azygous. So space 2 and 3, that does not go to the azygous directly, they go to the right superior intercostal vein. This is happening on the right side. Still, we have not talked about first intercostal space on the right side. The second and third, right superior intercostal. That drains into azygous. 4, 5, 6, 7, 8, 9, 10, 11 into azygous. Are we clear? Now, let's bring hemiazygous. Where is that? This is the one. Hemiazygous in the lower part. And look at it. On the left side, 11, 10, 9, 8. They are going into hemiazygous. And hemiazygous is connected to azygous. And then accessory hemiazygous for the upper spaces. 4, 5, 6, 7. They are going into left side. They are going into accessory hemiazygous, and accessory hemiazygous again going to azygous. So everybody is going to azygous. But there are few who are not following, who are not listening to us. Who are they? 2 and 3, posterior intercostal veins on left side. They are draining into left superior intercostal vein, and this one is not going to azygous, accessory hemiazygous or hemiazygous. This one is going to my brachiocephalic. This one is going to my brachiocephalic. So now we have covered from space number 2 to space number 11, all posterior intercostal veins. We know the differences. Guys, azygous is a very commonly asked topic. Now, the first intercostal space on the right side and first intercostal space on the left side, what is happening with them? They are going upwards directly. Supreme intercostal veins, and they are going where? They are going to the brachiocephalics. So whatsoever I have said so far, just look at in this image. We can see that on the right side, right internal jugular vein joins with the right subclavian vein. They are making right brachiocephalic, which is straight. On the left side, left internal jugular vein joins with the left subclavian vein, and they are making left brachiocephalic, which is oblique. It goes all the way to join with the right brachiocephalic. The moment they join, they form my superior vena cava. Are we good? Now the azygous on the right side is draining into superior vena cava. Look at the first space on the right side. Going where? Brachiocephalic. Second, third, fourth. Going where? Azygous. And we call it right superior intercostal vein. And then lower spaces all going directly to the azygous. Posterior intercostal veins. We also have anterior, but I'm not talking about them today. And now coming to the left side. The first space brachiocephalic. Second, third, and fourth through this one, again going to brachiocephalic, not like the right side. And then this space, 5 onwards, 5 to 7, 8. Guys, these numbers, you may find variation in the numbers 7, 8, 7, somebody is restricted at 7, somebody is restricted at 8. It's not a rocket science. So now they are going into hemiazygous, accessory hemiazygous, and it's going to the azygous. And the lower one going into hemiazygous, and they are going into azygous. So this image, this diagram should be very clear, space by space. Salman, it means when I was talking, you are not listening to me. I said you will find variation, 1 or 2 number plus minus in different books. I follow the previous one, but this image was taken from another source. It is showing like that, and I don't want to change it to show you the difference. So if you find it at your comfort zone, don't start, oh, what happened? There is a mistake here or there. There's no mistake. Yeah. You'll be tested upon. You know it. Now look at here. Yeah, both the sides, right and left. You can see that.
So the right one doesn't end up in the superior vena cava.
No. Superior vena cava only receives the zygous. No one else goes to. Now, why we are putting time on this azygous vein? That's my question. Really? Intercostal space is the heart? No. Yes, and look at it. If someone has blockade of superior vena cava at this place, now the whole blood from my upper body follow this azygous system of veins. So this azygous vein become big. Let's say they close Malik Fahad street. Now the whole traffic will be jumping on what? Takhasusi, Khurais. So there will be zahma. So now, once this is closed from here for any reason, now this azygous channel becomes super big, more dilated, because whole of the upper body blood will be going from here and going to the inferior vena cava, because they are connected in the bottom with the inferior vena cava, and through inferior vena cava, the blood is reaching to the right atrium of the heart. And vice versa, if inferior vena cava is blocked somewhere here, there is a cancer from the kidney which has gone into the inferior vena cava and it has blocked it. So now the inferior vena cava blood cannot go into the lower extremity, blood cannot go into the heart below the diaphragm. So what happens? So this blood will follow this azygous. And through the azygous, it will pour into the superior vena cava. And through superior vena cava, all the blood will be shunted into the right atrium of the heart. Are we clear?
There will be an increase in the right atrium pressure.
Why increase? Is right atrium is the receiving channel or a pushing channel? Receiving. So it was receiving from upper and from top and bottom. Now it cannot get from the top, and the top one is coming through another route. So there will be no significant change. Rather, there will be little less, because this alternate channel. You know, if you see in your common life, the normal flow on the Khurais, the normal flow on the Malik Fahad, if you taper it, what will happen? The traffic will increase or decrease? Decrease, because zahma, people will be going through the small streets, and that will not be meaningful. Are we good? Okay. So now this image is showing you some other interesting structure, and that green thing is the thoracic duct. What is this thoracic duct? All my body lymph, ultimately, after undergoing different processes, has been poured into thoracic duct. And from the thoracic duct, it is being pushed back into the venous system. Where? On the left side. It starts its journey on the right side, a dilated part in the abdomen called cisterna chyli. And then it goes, you can see that it deviates to the left side, and the junction between internal jugular vein and brachiocephalic vein. That's the commonest site of entrance of my thoracic duct. Suleiman, for you now. You'll read some other place. It will say it opens into the brachiocephalic. It will open into the internal jugular. All are acceptable. Thoracic duct receives whole lymph from left side and the lower bottom. Only the upper right half is going directly. So this whole body lymph is going through this thoracic duct and it is connected with the veins. Where? Most common site, the junction between internal, which left internal jugular vein and left subclavian vein. But it may enter into left brachiocephalic. It may enter into, so these are the locations. So then it has been part of your circulation. And for any reason, for any traumatic situation, if a damage occur to thoracic duct, the content of the thoracic duct is milky white in color. Milky white in color. Something close to laban. But laban, the one laban which comes iron, it is thin, iron. So this thin out whitish color fluid is present in the thoracic duct. And if someone has an injury to the thoracic duct, the content of this thoracic duct will leak into the pleural space. Now, we will not call it hemothorax. Now we call it chylothorax. And the diagnostic point of it, if you aspirate this fluid out, it will be milky white in color. It will not be pure white like milk, but it is little bit close to that. Are we clear? So that condition is called chylothorax. Now, we are good with this image. There is aorta. We talk about it. You have been explained about posterior intercostal arteries. I'm not spending time on that. We know that upper posterior intercostal spaces, we have the branches from the costocervical trunk, and the lower posterior intercostal arteries are the direct branches from the descending thoracic aorta. And then these are looking at the nerves. Thoracic duct, we talk about. Cisterna chyli, I mentioned about that. Sympathetic chain, gray and white rami committents, we talk about all of them. You can see them. Now we have these nerves, which are coming from a sympathetic chain. And these are greater, lesser, and least splanchnic nerves. And the word splanchnic, the other word for that is the visceral branches. So they are going and supplying adjoining areas. You can see that where they are going. The different plexuses, plexus around celiac trunk, plexus around renal artery. So these are the distributions which are going from the sympathetic chain. Are we good so far? Now, we know about this structure. You spend good time in GI, esophagus, which becomes stomach. This is my trachea, which bifurcates into right and left principal bronchi. Look at it. The right one is big, wider, less angular. Left one is short and long. The place where my trachea bifurcates, internally that area is called carina. I will take trachea again, there, with the lungs. So that place is carina. It has a high clinical significance, especially when we are diagnosing the cancers and all those things. I'll be emphasizing in more detail at that place. Are we good so far? So now, what are we looking at now? Right and left bronchi, we talk about it. You can see that this blue dot is the azygos. So now this is my pulmonary trunk. These are the pulmonary veins. Who was asking about esophagus? Now you can see it, Ahmed. You can see that esophagus, we put a contrast material, you can see the normal pathway of esophagus, just behind the heart. And these are the constriction sites. We know about them. You can see it. Guys, please be connected with this slide. In the next, I'm changing the position. Now, these star marks are showing the normal pathway of esophagus. Now, in this individual, there is showing what? The enlargement of the left atrium. And that, because of that, you can see the esophagus has been pushed backwards. It's not following these black stars. It's been pushed backwards. Are we good? So this patient will present to you, and this red dotted line is been showing the new position of the esophagus. And now this person will present to you with dysphagia. Are we good? Now, we were here. We know about this structure, arch of aorta. We know about, on the right side, brachiocephalic, right common carotid, right subclavians. Anything new here? Then we have left common carotid, left subclavian arteries. Aorticopulmonary window. This is where we have a lymph node. It might compress upon, if it is enlarged, it compresses upon left recurrent laryngeal nerve. And then we have harshness of voice. That I was asking today. And this is my ligamentum arteriosum. If it is patent, we call it patent ductus arteriosus. Now, these are my vagi. So you can see that the right vagus, it loops around. When Paul will be talking about bronchial arteries, he will be explaining why there are certain, they are staying and certain are disappearing. So on the right side, the vagus, it hooks around and gives recurrent laryngeal nerve. And on the left side, when it reaches to the, under the arch of aorta, you can see the left recurrent laryngeal nerve, which goes behind, which has been shown by this dotted line, going behind the arch of aorta and is going upwards. Are we clear? These recurrent laryngeal nerve are very important structure. They are controlling larynx, and I think Dr. Sheba will be explaining about the larynx in our upcoming session. Are we good so far? Now, these vagi, when they reach to the esophagus, they create this esophageal plexus. And we all know, we learn in GI, there is a rotation. And because of this rotation, now what happens? My left vagus nerve becomes anterior vagal trunk and the right become posterior. So now they are no more called vagus nerve, they are called anterior vagal trunk, posterior vagal trunks. Clear? And then we have the different plexuses, the cardiac plexus, all of them, they are getting their parasympathetics from vagus nerve and sympathetic from sympathetic chain. We talk about 1 to 5 distribution. So let's put the veins. We know about them, we have spent time on them. Just a visual. Right internal jugular vein joined with the right subclavian vein makes my right brachiocephalic. And then on the left side, left subclavian joined with the left internal jugular vein and they makes my left brachiocephalic vein. Look at it, it crosses all the way. And then they are making this number 7 is my superior vena cava. Are we good so far? This is all happening where? In my posterior mediastinum. This is my ascending aorta, pulmonary trunk. Now heart is here, right atrium. Appendages, we know about them, left and right side. Which artery is this? Right coronary artery, anterior interventricular groove. Who lives here? LAD lad. Today you had question on that. Okay, so now I'm bringing someone really important here. This is the one. Phrenic nerve on the right side, phrenic nerve on the left side. These are really, really important. And we love to ask about phrenics. They supply fibrous pericardium, mediastinal pleura, and then they go down to supply the diaphragm. They also supply the peritoneum and they become the cause of referred pain, which originates from your inflamed gallbladder and it refers to the tip of your shoulder. This heart has been covered by the fibrous pericardium. And now what we are left with the lungs, right and left? 3 lobes, 2 lobes. Guide mediastinal syndrome. Compression, basically the compression is the cause. Compression of the mediastinal structures could be anything. These are the different causes and these people will present with what? Engorgement of the veins, we call it superior vena cava syndrome. Dysphagia, if there is a compression. Dyspnea, difficulty in breathing, and that is because of compression of the trachea. And then hoarseness, so not for you, read this spelling. Don't bring it Hassan. So it's because of left recurrent laryngeal nerve. and erosion of the vertebral bodies because these vessels are caused. Thank you very much. You're welcome. Any question? Yes. Can you remove the mask from your face so I can hear you nicely? Oh, I love you. Chylothorax. Sister Nakai, the lymph when we receive from our GI, it gets this color because of the nutrients. And then it appears whitish, not pure white, whitish in color. That's why. And it's helpful for if someone has an injury to the thoracic duct, the fluid which will be accumulating in the pleura will be chyle. Any other thing? Thank you very much. Bye bye. You're welcome.